good morning. Welcome to the second live case in SNU Hospital. I'm Hyo-Soo Kim. My first operator is Jeehoon Kang, and assistant Dr. Minju Han and Jinan Song, and Professor Yeonjung Cho for anesthesia, and Dr. Jia, what's your name? Chejia, specialist from Medtronic. Okay, Dr. Kang, please explain your case.
Yes, welcome everybody. We prepared a nice case today for TAVI, and could you show us the slides, please? Yes. So this, next slide, please. So this is a 71-year-old, slightly young age compared to the general population that we do TAVI in Korea. And he was presented to the ER complaining of dyspnea with a functional class of NIA 3. So at this point, he was diagnosed as low flow, low gradient severe AS. And initially, because of the young age, he was admitted to thoracic surgery for surgical evaluation, but he was transferred to us because of the high surgical risk. Next slide, please. Yes. So this is the demographics. We can see that the patient has a lot of metabolic syndrome diseases such as diabetes, hypertension, dyslipidemia, and chronic kidney disease. The eGFR was about 46, which means that the chronic kidney disease is not that severe. But regarding that this patient has a long life expectancy, we should consider this as a nice risk factor. Next slide, please. So this is a medication, and this, you can see that the patient is on the 4 pillars of heart failure medication. And in the following slide, you will see the echocardiography. So for this patient, we planned TAVI using the evolute valve for severe AS. So this is the STS score, considering the factors of a urgent procedure and also the CKD status, and other chronic heart failure status with the ejection fraction of 20%. This patient was as a intermediate risk patient with a STS predictive risk of mortality 4.3%. Next slide, please. This is an X-ray, which is not that significant other than cardiomegaly, and also the ECG showed that this patient had a sinus rhythm. Next slide, please. Now this is the echocardiography. We can see that the LV is very dilated with low ejection fraction of 20%. The aortic valve is calcified itself. And what is important in this finding is that the right ventricle is quite well beating, which means that the damage of the myocardium is not to the right side. And also we can see that the right side heart is functioning well, which means that probably after TAVI, the patient might improve in the LV ejection fraction also. The mild pulmonary hypertension exists with an estimated PASP of 42 millimeter mercuries, and this will be explained in the following slides also. Next slide, please. So this is the echocardiographic findings. We can see that the AVA is 0.6 square centimeters with an AV max of 3.1. The mean pressure gradient was 22. We measured this invasively in this procedure right now. And the stroke volume index was below 35, which shows that this patient is a classical low flow, low gradient severe AS patient. In the CT images, because this patient was slightly young, we can see that the aorta is quite clean, and the coronaries were just intermediate or mild diseases. Next slide, please. As we can expect, the aorta had minimal calcification, which means that we can just focus on the aortic valve. Next slide, please. The diameters of the femoral arteries were quite favorable. The bifurcation was slightly high, but this was easily overcome by using sonographic puncture. Next slide, please. And this is the abdominal aorta. Next slide, please. Now, the calcium volume was not that high. In the contrast volume, it was 457 3 square millimeters, which showed that it was quite evenly distributed. The Agassiz score in the non-contrast was 1700, also showing that it was not that much high. But again, we should consider that this patient is a low flow, low gradient, not a classical calcific AS patient. Next slide, please. The annular size were as follows. The diameter was average 23.9. The LVOT was slightly larger, 24.7 millimeters. Next slide. The sinus of Valsalva was quite large compared to the annulus and the LVOT, which means that there may be a lower risk of any kind of coronary obstruction, but also we should consider that the coronary heights. The ST junction was 30 millimeters, again, slightly larger than the annulus. The coronary and ST junction height were as follows, and we can see that considering that this patient has a large sinus, that there may be a very low risk of any kind of coronary obstructions. But because, again, this patient is young, we should consider any kind of future events that we might need any kind of intervention or even valve-in-valve. Next slide, please. The membrane septum length was 6 millimeters, slightly larger than the average Korean length. But again, this should be considered when we insert the valve deeply in the patient. Next slide. This is the best implantation view, the 3-cusp view and the cusp overlap view, which will be shown in the procedure that we'll do today. Next slide. So this is the measurement of the dimensions. So the annulus was around 23, 24 millimeters with a perimeter about slightly lesser than 80 millimeters. The annulus area was slightly larger than the small annulus definition that we have. So this patient was not a small annulus patient. And other numbers was also quite favorable for the procedure itself. Next slide, please. So if we use the SAPIEN 3 Ultra, we would have a oversized index of 16% at nominal, which was slightly large. Next slide. If we use the Navitor, we would have a oversizing index of 14% with a 27 millimeter Navitor, which was slightly lower than the optimal oversizing index that we have in our center. Next slide, please. So if we have the Medtronic, we can use a FX 29 millimeters with a oversizing index nearly 20%. And considering that this patient is a young patient and the sinus is large, probably we thought that this would be the nice valve for this patient. Next slide, please.
Okay. After presentation case, we prepared 2 discussion points. The first one is this patient has classical reduced ejection fraction, low flow, low gradient severe AS. Prognosis is the worst among the several kinds of AS patients after TAVI. The second issue is choice of TAVI valve. Plus, here is algorithm of severe AS diagnosis. The first, on the right, high gradient, no problem. On the left, low gradient. Even though valve area is less than 1 square centimeter, gradient is low. Then we have to check volume, stroke volume index. If it is less than 35, low flow, low gradient AS. Then we have to check ejection fraction. It is below 50%, classical, low flow, low gradient. It is normal, paradoxical, low flow, low gradient AS. For these patients, classical low flow, low gradient, we have to do Doppler stress echo to define the true severe AS, but Korean reimbursement guideline does not require Doppler stress echo at this moment. Plus, how about prognosis? In this paper, suggest 1-month mortality, 1-year mortality was highest in classic low flow, low gradient AS. High gradient AS, best prognosis after TAVI. Intermediate is paradoxical, low flow, low gradient AS. Plus, but in other paper here, paradoxical and classical low flow, low gradient AS as a similar worst prognosis after TAVI. Here, severe death after TAVI was highest in paradoxical and classical low flow, low gradient AS. Best prognosis, high gradient AS, especially normal ejection fraction. Plus, second is choice of TAVI valve. This patient is 71 years old with some degree of coronary lesion. Thus, we have to consider several points: future coronary accessibility, future TAVI and TAVI procedure, valve orifice area, and durability. We can use all 3 kinds of TAVI valve available in South Korea for these patients. SAPIEN 3 Ultra is good for future TAVI and TAVI. Navitor Vision provide wider orifice area. Evolute FX provide a wide area, commissural alignment is possible, and confirm the durability. Plus, here is the Evolute FX, the newest version of the Evolute series from Core Valve, R, Pro, Pro Plus, then FX. I think three merits are new. The most important thing is radial PAC3 markers that is helpful for depth and commissural alignment. Second, optimized stability layer that is helpful to do a stable deployment process. And single spine shaft provide very soft shaft. Plus, when you consider future TAVI and TAVI in evolute TAVI valve, you have to remember commissural height becomes nail skirt during future TAVI and TAVI. Here, E is commissural height that becomes nail skirt when you do another TAVI implantation inside of the failed evolute. All the same, 26 millimeter. Please remember 26 millimeter plus. Our plan, we implant evolute FX29 considering future TAVI and TAVI, 71 years old patients. First, commissural alignment. Second, implantation depth. How to do commissural alignment? Before arch navigation, we always use deep LAO. That separate right and left cusp. In this view, head marker should be on the great curvature of arch. After navigation of arch, at the annulus level, we change right, left overlap view, arteriocaudal. In this view, head marker should be on center front. And 3 dots, 2 on the left, 1 on the right. Second issue, implantation depth, deeper for the future TAVI and TAVI. We would like to target deeper than 6 millimeter. Then in the future, nail skirt height should be 20 or less. Considering the ST junction height more than 22, 20 millimeter nail skirt would be safe. Of course, coronary height is below the nail skirt, but sinus space is wide enough. Thus, there is no chance of coronary obstruction or ST junction sequestration in future TAVI and TAVI. Deeper may induce AV block, but this patient has long MS length, 6.4 millimeter. That's probably not a major issue. Okay, please discuss this case while we are going to do procedure.
Thank you for excellent presentation, Dr. Kim and Dr. Kang. So I have some wondering. The patient is very young, 71-year-old, but less severe calcification and 3 cusp, not bicuspid. But even though this characteristic, patient ejection fraction is very low. So I assume CVOS can only CVOS can induce this very low ejection fraction. The other dilated cardiomyopathy, another cause of the failing myocardium might exist after successful TAVI. So I recommend the evaluation, including cardiac MRI for his cardiomyopathy. And then I suggest shallow implantation is important in this patient because low ejection fraction, the development of complete AV block may worsen his clinical course. So, any other comment?
I guess
so you expect his life expectancy is less than 10 years. So there is no chance of future TAVI and TAVI.
Yeah. So Evolute is good, nice choice.
I think you could do. I mean, I think you can justify almost any choice here. Evolute is fine and very nice. I think in the U.S., I do think we would be concerned a bit about the moderate coronary disease that this patient has with diabetes and renal failure, and I expect this patient may well need a coronary intervention in the next 5 years. And so I would want to make sure that we had good access. Now in the States now we have the next generation of Evolut. We have the FX Plus, where we have the large cells that if we achieve good commissural alignment, we can place over the coronaries. And so that is an advantage there. Obviously, I think a Sapien would do fine as well and give you the best coronary access, but I think this is a perfectly nice choice. And it's nice to have a case where we're not constrained too much.
Well, sorry to interrupt during your discussion, but for this patient, we use this view, which we call the cusp separation view, which shows that the NCC is in the back with a three-cusp view, with a different three-cusp view that we have. The reason that we use this view is that we think that this is the optimal view, that we should make the hat marker to the far outside in the descending aorta, because the valve will follow this course, course for the aorta, and this is the final view that the hat marker should be on the outer side of the aorta when we come to the aorta.
Let me explain. 금방 그 view 한번 볼까? You may be not experienced with such kind of view. This view is a right-left sinus separation view. On the left, that was right sinus. On the right, that is left sinus. Center, NC sinus. Actually, NC sinus is behind the screen. So we have to separate right and left sinus. That is exactly 90 degrees difference from the right-left cusp overlap view. In this view, when we sit the hat marker extreme right side, then cusp overlap view, that hat marker should be center front, because the projection angle is exactly 90 degrees different. But sometimes such a right-left separation view was not achievable because of too deep LAO cranial view. But happily, these patients, it is possible to get such a kind of interesting right-left cusp separation view.
So the angle in this is LAO 38, cranial 34, so we'll go to that view. And this is what we see right now. So if we just slightly have a rotation, which makes the flush port to about 2:30 right now, we can see that it's on the outside. So we will progress along the arch and the
Okay. Wire.
Is this a Safari wire or a Confida wire?
Safari wire.
Safari? Great.
Safari wire. We have some interaction with the pigtail and the Safari wire.
In this kind of horizontal aorta, very deep angle, it's better to use Confida instead of Sapien. Instead of
쭉 더 넣어야지. 잠깐만.
In patient with
you use how do you use the
You can
snail?
use the pigtail to move the valve. I've never seen that before. Yeah.
The people snail you
Like a snail.
tried but failed and then use snail.
안 들어가? 킹킹?
Yes.
Okay. Pigtail 가볍다 is kinked. Why advance 안 되나? Okay.
in patient with low gradient patient, hemodynamic instability can occur during the valve implantation. Sapien 3 Ultra and Navitor takes a relatively short implantation time. What do you think about that?
We would like to avoid rapid pacing for Sapien other caudal view.
Test.
Deployment process, I think there's no difference between tablet and navitor. Of course, intraannular valve design open valve earlier than supraannular valve design. Okay, test it.
Test.
Okay. A little bit oblique. This so.
Can you
No.
show the
Converse,
3 dots?
no change.
I'll just do this one.
A little bit.
Yes, if you can see the dots right now, 2 are on what we can just see. So 2. So obviously 2 are overlapped. And because we think that this is quite center front, we will proceed with the procedure. 알겠습니다. Deploy.
잘 안 보인다.
잠시만. 네, 올려주세요.
각도가 너무 스티프해서 그런가?
Deploy. Test.
Okay. 4.5.
Deploy. Test.
5.
Deploy.
Dr. Hyo-Soo,
저장.
do you prefer the 3 millimeter
Test
depth or
테스트.
the Dr. Kim want 4.5 millimeter?
So actually, from this
Six.
level of view, so I tend to deep a little bit deeper,
Now depth would be about 6.
and because if we go to the LEO view, it tends to be a little bit shallower,
8.
and this patient has the little bit spacious membrane acceptance. So I agree with the Professor Kim that we can try from 4.5 as far as there is no conduction disturbance.
테스트 준비.
테스트.
Are we doing control pacing now?
좀쭉 가지. 좀 더.
오케이, 이 정도.
오케이.
자, 한번 볼까? 자, 한번 각도 맞춰볼까? 카우달, AP 연절의 카우달
오케이.
맞나?
좀만 더 카우달.
조금 더 카우달.
Yes. Okay. This is okay.
자, 쓰네.
Reducing 신뢰.
I think it is about 6 or 7. Head marker should be about 4.5 from the bottom of the frame, right?
Yes.
And the AD conduction, no problem.
So
커스 오블렛비엄, 뭐야, 3 커스비엄 가볼까?
another point that we observe in the evolute valve is that there is a auto tilting, which shows that this is the original 3 cusp angle of this patient, and we can see that it's not, there is parallax.
다시
But probably
previous
after the deployment, this will be corrected a little bit, and we have to see how that works.
there's some parallax. So we have to adjust the angle depending on the frame. So this is a frame-oriented angle. So annulus is oblique in this point. Well,
Okay, yes.
in this point, times are enough. I think the depth is good.
So,
Thus, I can finalize this procedure at this depth. But before a final release, I'd like to show you the several images. T,
okay.
okay, T. For the educational purpose, we perform this process under general anesthesia with T insertion. Thus, I believe the procedure time of evolute is not so long. It is experienced. It is not so different from the sapient procedure as well as Navita.
So from the short axis that you are seeing right now, we can see that the valve is slightly oval, but probably this will improve after we do the final deployment. We can see that there's a large amount of sinus space, again confirming that there is no risk of any kind of coronary obstruction in this patient. If we go to the long axis view, we can see that if we can evaluate if there is any interaction with the mitral valve, obviously there is none in this patient, and there wasn't any kind of risk for this patient either. Again, we can see that the valve is slightly deeper in the anterior side and slightly shallower in the posterior side in the long axis view again. Again, this correlates with the finding that we have to go caudal to make the valve parallel to the view that we have. So this is the usual angle that we have when we deploy the valve.
Is there echo specialist there?
We are specialists, at least TAVI echo. We don't need
By T.
another doctor because that is a kind of cost.
2 weeks ago, the Japanese doctor showed the ICE intracardiac echo. He showed the very clear image of membranous septum by ICE.
Yes.
Can T show the membranous septum?
Well, in my opinion, the membranous septum is slightly difficult to see in the T compared to ICE. So ICE is more easy because it goes into the RA and looks at anterior to posterior. But the T is on the opposite side. So it will be able by nicely specialized specialists, but actually we couldn't find it in the image that we prepared today.
But you're a specialist. If you cannot see, it is unsealed with TEE. Okay, can you see the color? There is some leakage, paravalvular leakage around left and none.
Yes.
Okay, left and none, 12 o'clock. Commissure between left and none. Okay, thank you very much, Dr. Song. Can you return to the... Okay, we are going to just finalize the procedure. It's
Yes.
too early. About 20 minutes left. How
You can
Do
do
we
another. We will watch a second
entertain
one.
them?
Yeah.
Okay,
So I will just relieve the tension from the Safari a little bit. And with a slight push, I will do the finalized deployment. Deploy. 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 Deploy.
the shaft is well coaxial.
Deploy. Oops. Deploy.
저장.
Okay, now from the image that we just saw, because we have a lot of time, we can see that at this point the 3 dots are on one line, which means that there's no parallax in the valve, but there obviously is parallax in the native valve. But when we do a final deployment, we can see that there is a difference in the 3 dots that we can see right now. So we will evaluate which dot is in front and which dot is in back
저 빼고 나서.
after removing the valve. Okay. Okay. 3 cuts of view. Is this a 3 cuts of view? Yes. So if we go to the 3 cuts of view, this is the 3 cuts of view that we have right now. So we can see that there's disappeared parallax from the valve. However, in this identical angle, during the deployment, this is what we had. So we can see that there's a auto tilting from the envelope valve, which at least had, which was better coaxial to the native valve right now.
Before finalized release, the valve is tilted toward right side, right non-cusp. And after finalized, they auto-tilted toward more aligned with native valve.
테르모.
During deployment procedures, some doctors prefer the pacing, regular pacing. Most doctors in Korea adopt pacing 100, 110 during deployment of Navitor. Some guys use pacing even in Evolute. But in this case, the LV EDP is about 40 millimeters of mercury. Thus, I don't touch the LV stress. Thus, we skip the controlled pacing.
So we'll do a SINA and see if there
다시
is.
조금 더 맞춰볼까 밑에 이거를 LAO. Okay.
Do you prefer the TPM approach via transjugular approach?
리그스테이션 있네, 그죠? 다른 각도가 아래로 카우달 뷰, 커서 바벳 뷰.
Oops.
The oversize index is about 20%, and the analyst classification is not so remarkable. I don't understand why such kind of leakage.
We'll just do a T evaluation again.
Too much volume or contrast.
Too much contrast.
Iatrogenic. Yeah.
Iatrogenic?
Yeah. Iatrogenic central. Yeah.
So let us see the T once again. Swelling regurgitation. Okay, there is a definite paravalvular leakage at the commissure between left and non. So wire is not wire? It's
No, it's not.
definitely paravalvular.
Yes.
Okay, so we are going to do post-ballooning.
24.
잠깐만. 자, T 좀 올려줄까? T 좀 치우고.
Can you show the CT image initially presented?
Yes, we will.
슬라이드 CT 한번 보여줄까요?
Yeah, I don't remember there being any major calcium there. Yeah.
시스 주세요.
She's
Nothing. Nothing.
So we want to see the images between the LCC and RCC status.
there's some commissioner classification between left and non, but considering the degree of calcification, I think the leakage is too much.
What size balloon will you use?
We're planning to use a 24.
Great.
So is that according to native anatomy or?
It's according to the native anatomy.
플러스 슬라이드 애널리스 사이즈가 얼마죠? 슬라이드 아까 23.24 okay.
Yeah, 24 is good. Yeah. And just keep it away from the valve and towards the annulus.
So which balloon would you choose? VMAT or other balloon?
ZMED
ZMED, yes.
okay.
Okay.
Yeah, I'm surprised of the degree of regurgitation as well. This looked like a valve that would be very favorable, but I think the post-dilatation will fix it, I hope.
됐고. 많이 잡고.
LAO.
그냥 놔두지 뭐.
아,
아레오 카우더이 제일 좋으니까 그대로 놔둬. 픽테일. 픽테일. 오케이.
여기서 할까요?
잠깐만. 프로. 오케이.
Okay, rapid pacing
On.
on.
에이, 아.
Slippery. Yeah.
Yes, we'll do it again.
빼고. 오케이. Pacing on.
Deflation. 네. 스테이 하면서 빼겠습니다.
온라인 좀 맞춰주고 파렐렉스.
오케이.
안 맞잖아. 카우다운 해야 될 거야. 그 말고 그러면 잘 안 보이니까 약간 LAO로 하면은 맞아치잖아. 안 맞잖아 지금 3도트가. 오케이 좀 더 오른쪽으로. 오케이.
여기서 하겠습니다. 진행하겠습니다. 진행.
That's better.
Yes.
오케이 자 그 와이어 스위치 할게요. 자 먼저
Can we
볼륨
see the TEE again to see?
Yes, we will. Yes, we will. 피그테일 주세요.
remarkably reduced.
Almost gone. Almost gone. Yeah. Interesting.
Well, another finding that we have is that probably calcification in these kinds of patients, it's not the only cause of stenosis. Probably there's fibrous tissue, which is also important in the stenotic portion. And this was also shown in the previous report from JACC Imaging in 2024. And actually, this will be presented in the following fourth TAVI case from our center.
So when you say in these kinds of patients, do you mean a patient with renal insufficiency or something else, or a patient with depressed LV function?
With a non-calcific patient with a low flow, low gradient, which cannot be explained by the traditional numbers that we usually know.
Okay, so the absence of calcium with significant AS makes you think
Yes.
the leaflets are stiff. Yeah.
Yes.
Traditionally, calcium is the only factor to induce sclerosis and leaflet and aortic stenosis. But now, fibrocalcific, the total sum may be the right determinant to induce sclerosis of leaflet and aortic stenosis. In the second case this afternoon, we have less calcium but severe aortic stenosis with paradoxical low flow, low grade AS.
Can you
Will be
show
presented.
pressure? Oh, yes. So this is double tracing right now.
Pressure profile.
The EDP is slightly high, as you can see, but this patient was 35 before the procedure. Can you show us the Excel slide, please?
So pulse pressure is not so wide, thus that means there is no significant regurgitation. Please hold. We developed new AR index.
What is it? There's a new one?
It's the new AR index. There's a previous AR index, what we have right now, and in the Excel slides that you will see in the second, you will see the calculation.
Great.
So we will have a SVP of 130, a DBP of 72 as is shown in hemodynamic assessment. The LVEDP is 35. The dicrotic notch would be 90. So in this slide, you can see that the AR index is 23, the new AR index is 3.9. And considering our investigation, we think that the new index is more nicely correlated to aortic regurgitation after the procedure itself.
Which was published in JACC Intervention. The newer index is more predictable, more accurate than traditional AR index. So in this patient, newer index is about 3.9. About 4.0 is ideal digit. So this is very close to ideal status.
So I'm not familiar with that study. So did you test this against cardiac MR, regurgitant fraction, or something else?
No, actually, it was a comparison with echocardiographic evaluation.
Okay.
Okay, remove the ventricular catheter.
I think that the numbers are quite okay.
넘겨주고요.
And we will do a final few shots for this patient.
좀 안 맞네, 밑에가.
So did this patient had long-standing heart failure before the aortic stenosis? I assume because they were on all the right drugs, or is that a misassumption?
Well, actually, that was in this event because this patient didn't go to the hospital before this current event. So the first ejection fraction that we met was 20%, and the medications were started after admission.
Ah, okay. So it could be that this is all from aortic stenosis.
Yes. So considering that the LV EDP is high, the LV is enlarged, but the right ventricle is still quite normal. We assume that if we do a TAVI procedure, as you shown in our discussion slides, that the LV mass index might decrease, the EDP might decrease, and the EF might improve, which will be probably very significant for this patient's lifelong expectancy.
Yeah, I'm sure.
But as I previously reported in my presentation slide, the prognosis after TAVI is worse in this kind of patients. Classical low flow low grade AES as well as paradoxical low flow low grade AES compared with high grade AES.
Yep.
So this will be 실례하겠습니다. 실례.
Oh, looks great.
So we didn't reduce the contrast volume, and we can see that there's a decrease in the regurgent flow.
So I'm happy with the depth. That is about 6 or 7 millimeter ventricular. Thus, there is no change of AV conduction. And in the near future, and in the remote future, if the patients experience degeneration of alveolar valve, then he should undergo TAVI and TAVI. And that time, the nail skirt height is 26 millimeter above the bottom of the frame. Now, nail skirt height is about 19 millimeter above the annulus. That is well below the SD junction. Thus, there is no chance of SD junction or coronary obstruction. Thus, there is no need to do a basilica procedure.
This is the native cusp overlap view, and from this, we can see that there is a slight rotation. It's not bad. The alignment is not bad, but there's slight rotation. We can evaluate then that from the dots and also from the CTAP.
In this view, this cusp overlap view, if the well-aligned the valve, 2 dots on the left, 1 dot on the right side. But 2 dots are a little bit separated. That's not so bad, but not perfect alignment. About 10 degrees just moved from the good alignment. How about tricuspid view?
So if we had the FX plus with the large coronary ostium, probably this would be within the large ostium, so it wouldn't give any interruption to coronary engagement in this kind of
Original
misalignment.
tricuspid view?
So this is the tricuspid of the original view. And we can see that
In tricuspid view, the 3 dots are equally distributed. But the center dots move toward the right one. Thus, it is not perfect alignment. So it is displaced about 15 degrees. Thus, that is called, we called it as an intermediate alignment, not bad alignment. Bad alignment is 60 degrees displacement. There's 45 to 60 degree displacement is bad, and 15 to 45 intermediate, less than 15 a good alignment. So this is the border between the good versus intermediate alignment. Thus, I think the post is not in front of the coronary ostium. Thus, in the TAVI and TAVI procedure in coronary engagement, the post may not be a hurdle. Why we could not achieve the perfect alignment? As you can see, we just navigate and there is a tangle between the pigtail and the device. And that process, I think the angle is a little bit rotated. 아까 못 가 쭉 가가지고 아래 카달 뷰에서 보면은 minus okay. This is the aerial caudal view just at the starting moment of deployment. In this angle, the head marker should be center front, but head marker is a little bit deviate toward the left side. He tried to rotate the shaft to make the head marker on center front, but it was difficult.
it didn't have so.
Because FX is single spine and very soft. So after navigation through arch, the torque transmission is very poor. That's the same as the Navitor. But when we try to rotate to make the head marker on center, the commissure would be perfect. But a little bit oblique, this commissure is just displaced by 10 degrees or 15 degrees. But such kind of displacement is no problem in coronary accessibility or TAVI procedure. Okay, final answer.
어디서 찍을까요?
다 찍었나 이제?
네, 다 찍었어요. 커스버 오버랩에도 안 찍었는데.
아까 커스볼 맨 찍은 거예요?
요거만 다이는 안 썼습니다.
Okay, thank you. Great job. I'd like to close this session. Before closing, any comment from panelists?
I think it's a very nice demonstration, especially I have not seen the cusp separation view used before. That's something new for me. And so I learned about it. And it's, as always with Dr. Kim and his team, it's expertly deployed. I learned a lot about how to deploy core valves from Dr. Kim from these courses over the years. So it's a treat.
Thank you very much for your compliment.
Congratulations, Dr. Kim and Dr. Kang.
Bye.
And we are closing this session.